Good afternoon. Abnormal uterine action. Okay, tell me, what is polarity of uterus? What is polarity of uterus?
When upper segment contracts, lower segment relaxes. Uh,
Okay,
The
then.
pacemaker of one at each. Ma'am, when upper segment contracts, lower segment relaxes. That is polarity, man.
Okay, good. Okay, we are discuss what are the classifications of abnormal uterine or the type of abnormal uterine contractions. Tell me what are different types.
Spastic lower segment colicky uterine
Okay.
asymmetrical contraction, generalized tonic cervical dystonic.
Okay, very good. Okay, you have seen here, this is the pacemaker, no? This is a pacemaker, actually. Okay. This is a multiple pacemaker, actually. Okay, we already
Yes,
talked
ma'am.
about it, yeah. This polarity of the uterus, pacemaker, then pattern of the contraction, and also we already discussed the the frequency means the tone, basal tone. It is a basal tone, base tone means a minimal tone is how much the uterine tones is minimum in the mild pain when the pain started and the true contraction started, the true labor pain started. It start from this minimal pain. But this basal tone is how much? 5 to 20 mm of
5 to
Hg.
20 Hg.
Yes, all right. Then peak is how much? The peak is up to 60 mm of Hg. Okay, then let's continue. We already discussed what is precipitate labor. We already discussed
Then
what.
5 to 20 Hg.
Yes, all right, all right. Okay then. Now we'll continue with the what we have left. We already discussed what
60
is.
Hg.
Yes, yes. All right, all right. Okay. We already discussed what is precipitated. What is precipitated labor, the complications, management of precipitate labor. Then we already discussed the excessive uterine contraction, retraction ring, and bundles ring. Now, then we already we already discussed hypotonic uterine inertia till the management. Now we'll discuss the hypertonic uterine inertia. Okay. Okay, now we will discuss hypertonic uterine inertia. Okay. Okay, we have seen one type of the abnormal uterine contraction is colicky pain, hypertonic, then spastic. Okay, so let's see the type little bit. In this hypertonic uterine contraction or inertia, it is a type. There is one type is called colicky pain, colicky uterus. This colicky comes from the words colicky pain. Then this is the pain which is experienced by the mother, okay, during contractions. It is very, very sensitive and painful, even to touch for a means upper in the abdomen of the mother. So it is what is this? What is this colicky uterus? In coordinations of the different parts of the uterus in contraction. It is what? It is in coordinates of the uterine of the different parts of the uterus in contractions. It is not coordinate. Actually, in the true labor pain, it starts from the two pacemaker, that is conva, nearby the conva of the uterus, and coordinate from the upper segment will be contract and the lower segment will relax. But this time, this colicky uterus will not be coordinate. There will be sometimes there will be severe pain, then upper segment, the lower pain there will be no retractions. There will be pain, even contractions, even in lower segment part also. Then another one, hyperactive lower segment, lower uterine segment. This type of pain or it is what? So the dominance of the upper segment is lost. Here the pain will start, maybe the pacemaker will start from the lower segment. There will be no dominant of the contractions, which is actually normally start from the upper segment, but here there is no dominant of the upper segment is lost. There will be relax of the lower abdomen, then contract of the upper abdomen, and relax and will be contracted the lower segment. Clinical picture. The condition is more common in primary gravida and characterized by what? Labor is prolonged. Here the mother will have prolonged labor. The thing is, we used to see actually that you don't see here because less mother in which is like in NEIGHRIMS, but in Kanishdas you will see all this. You really see the mothers with this problem also. Then uterine contractions are irregular and more painful, like this colicky pain, hyperactive, because the pain is contraction is quite active. Then high resting intrauterine pressure in between uterine. Then contractions detected by topography, which is normal values. You see, minimal tone of the contractions is how much? 5 to 10 mm of Hg. But here the high resting means pressure, uterine pressure is in between uterine contraction detected by topography. In the upper segment, that is in the upper segment. Then slow cervical dilatations. There will be the signs of the cervix will not dilate. Premature rupture of the membrane. Premature rupture of the membrane means the membrane will be rupture and fetal and maternal distress. Why fetal and maternal distress? Fetal because of strong contractions maybe in the lower segment, but there will be no way out, means because of that contractions there will be no the cervix is not dilated. There is no way out for the fetus or the presenting part to escape from the areas, from the passage. So what happened? There will be fetal distress. The pressure will be more in the fetal side. And the mother distress. Why? Because of severe pain. The mother cannot bear a pain. That's why there is maternal distress. Management of the hypertonic. What is general measures? We have to do just like hypotonic. But here there will be no. They will not give any this one. There will be no syntocinon will not be given in a hypertonic uterine inertia. But measures like here as then one we have to do another measures like we have to do positions of the mother, then the psychological support of the mother, then lie the mother in the lateral positions, and then emotional support to the mother. All these general measures will be given. Check the hydrations of the mother. Check them. Monitor the fetal heart rate. Then assess the mother, all the vital signs of the mother, because mother distress also will be present. Then your presence should be always there with the mother. That is the general measures. In medical measures, what we will give? Analgesia and antispasmodic as pethidine. They will be given but with keen observations or strict vigilance for the fetal conditions. Means continuous monitoring of the fetal heart rate. Then epidural analgesia may be a good benefits. In a low dose, they will give epidural anesthesia. If there is no facilities, they can give it pethidine or other analgesic or antispasmodic. Then mother, if it is so severe, there will be chances of what? But there is a chances of rupture of the lower uterus because of the strong contractions. So what happened? It will be cesarean section is indicate in case what? When it is failure of the previous method. Failure of analgesic, failure of there is no improvement like dilations of the cervix and all, there is no, then they will do cesarean section. There is also fetal distress is present, especially if there is compromise in for the fetus, they will do CS. Then these proportions when assessed, there will be CPD, means the pelvic is not appropriate or maybe big babies, then they will do CS. Then fetal distress before cervical dilatations. Then there will be these are the things they have to do for uterine contraction when there is hypertonic uterine inertia. Okay, next one is constrictions. Another abnormalities like constriction, contraction ring. Okay, in this constriction contraction ring we have already come across with the contraction ring, bundles ring. Okay, it is from there only. It is persistence localized annual spasm of the circular uterine muscles. It occurs at any part of the uterus, but usually at junction of the upper and lower segment. Okay, I already shown you also what type of, but the bundles ring. This is one of the ring. It is persistence localized and annular spasm of the circular uterine muscles. It occurs in any parts of the uterus, but usually at the junction of the nearby junctions of what? Of the upper segment and the lower segment of the uterus. This occur and this constriction ring will occur when during the first stage also it will occur. There will be during the second stage also will be occur, and even during the third stage also will be occur. We already dealt with that. Means when it comes to retained placenta, we have to check. Like last time we are discussed the or class contractions. That is one during the third stage of labor. There is chances of retained placenta. In the first stage, there will be no development of the first stage of labor, even in the especially in the active phase in the first stage. Then second phase, then when the contraction there will be there will be no contraction. I mean like dilations of the cervix will be there. Then this is a constriction ring. See, it's happened. See, between the junction of what? Between the junction of contractions of the upper segment and lower segment. Etiology. Unknown but predisposing factors are, it is unknown, but the thing is, it might be because of malpresentation. Malpresentation and malpositions. Here it comes to the passenger. Means malpresentations, the fetus, means that the fetal parts there will be a malpresentations. It can be face, it can be face, or it can be the face presentations or the brow presentations. And malpositions mean due to the positions of the fetus. It is not in normal like left occiput anterior or right occiput. It can be anterior, it can be posterior occiput. Then clumsy uterine manipulation, underlight anesthesia. Okay, manipulations like underlight, there will be a faulty, like means a clumsy uterine manipulation. Under what? When they give anesthesia. Then improper use of oxytocin. Then when we are faulty use of these oxytocins, there will be chances of these constrictions. Then use of oxytocin in hypertonic and inertia. That's why in hypertonic inertia, we never use oxytocin or syntocin for induction of labor. This is improper use of oxytocins means for induction of labor. Then IM injection of oxytocin, so it can occur. Because this problem occur, it can be occur when? Even during the first stage of labor, the second stage of labor, and the third stage of labor. See, IM injection we will give commonly after the third stage of labor. There will be a chances because of this one improper use of oxygen during this time. So that's why constriction ring occur. Then diagnosis. Continue then. This diagnosis, the condition is more common in primary gravida and gradually and frequently preceded by colicky uterus. This colicky uterus, I told you, is painful and many pacemaker will be there. Not only two pacemaker, it will be multiple pacemaker will be there. Mother will experience a pain which is very, very sensitive and very painful. It is agony pain for the mother she experiences. So this pain and there is chances of constriction ring. Then the exact diagnosis is achieved only by feeling the ring with a hand introduced into the uterine cavity. Here they used to introduce means they ring means only by doing means with the hand introduced into the uterine cavity means internal examinations will do, and also it can be means they used to detect after LSCS. Management. In management is exclude what will do malpresentations, malposition, and disproportions. Okay, then we have to exclude in the management, exclude this. So in the first stage, otherwise we will send for LSCS. In the first stage, pethidine may be benefits. To reduce pain, that colicky pain and the pain which is unbearable pain, we have to give betadine to the mother. But remember always, when we give, there will be respiratory distress to the baby. That's why continuous monitoring of the baby, conditions of the baby, or the fetal heart rate should be continued monitoring. In the second stage, deep anesthesia is given to relax the constriction ring. In the second stage, know that, I hope you understand, you still remember. Second stage is means when the full dilatations of the cervix and then it's end up to the delivery of the fetus. That means in the second stage, we can give deep general anesthesia because we already know that the mother is going to deliver within no time. Okay, so if the ring is relaxed, the fetus is delivered immediately by doing what? You have to do forceps. Anesthesia will be given, forceps will apply. If the ring does not relax, if the ring is not relaxed, what we will do? Only if the ring is relaxed after giving anesthesia, means mild first, then we will do forceps, then immediately we will deliver the baby. But if the ring is not relaxed, immediate LSCS will be taken for the mother. Lower system vertical incisions is to divide the ring. Okay, they will do LSCS only, but in vertical incision, not this one, horizontal. In the third stage, if it's happened in the third stage, now we just remember that the first stage, what happened during the first stage, betadine will be given. In the second stage, deep anesthesia will be given. Simultaneously, they will have to do immediate and quick delivery with the forceps. But if it's not relaxed, LSCS, vertical incisions will be done. Because the ring you have seen there, what type of ring, which is constrict in between the junction of the upper segment and lower segment. Now, in the third stage, if it happens in the third stage, that means already delivered the baby, but there will be retained placenta, deep anesthesia again will be given, manual removal of the placenta will be done. Okay, now this is done, finished with the constriction ring. Okay, understand?
Yes, ma'am.
Okay, we already discussed what? The multiple, okay, that is abnormal uterine contractions. We have done hypertonic. We have done what? We already discussed the constriction ring. Now we'll come to cervical dystocia. From the word itself, we know that cervical means cervix. Dystocia means difficulties. That is a failure of the cervix here. What? To dilate. Okay, actually the dilations of the cervix will start from the 1 centimeter to 10 centimeter. But here the cervical dilatations is not, it is failure. Within the recent time in spite of good regular uterine contraction. Within the recent time. See, remember during the latent phase, first stage you start from the time of true labor pain to till the full dilatations of the cervix. This is 10 centimeter. Here, it takes maybe around 12 hours for a primary mother. And also remember that during the time also there will be latent phase and active phase. Latent phase means from 0 to 3 to 4 centimeter. And the active phase from the 3 to 4 centimeter to the fully dilatation of the cervix. But that time it takes for 12 hours for the primary and 6 hours for the multi. Here, in a cervical dystocia, when the time given means the time is up, there is no improvement in the dilatations of the cervix. Variety, there is organic or secondary due to what? If it is organic, okay, it can be due to what? Cervical stance. Maybe the problem with the cervical only as a sequel to previous amputations because of maybe history of any surgery or any problem with the cervix of the mother. Then cone biopsy, mother will undergone or the cone biopsy for any detection or for any detect of LSC or any problem. Then extensive cauterizations or obstetric trauma. Okay, in the organic can be because of the maybe previous history of the mother with surgery or any biopsy or cauterizations of the cervix or because of the trauma. Then another one is or lesions as there is a cervical myoma or carcinoma. These are a problem in the organic. Then functional or a primary is We have then the secondary, then in the primary, in spite of the absence of any organic lesion, any organic which is related to the cervix problem, and the well effacement of the cervix, the external os fail to dilate. In spite there is no surgery, then there is no myomas or sarcoma, then or any problem with the cervix, but the means effacement of the cervix is failed. So it falls in a functional or primary dystocia. This may be due to the lack of softening of the cervix during pregnancy or cervical spasm resulted from overactive sympathetic tone. Complications. The complications here, then in the complications there will be annular detachment of the cervix. What happened to this? The bleeding from the cervix is minimal because of fibrosis and a vascular pressure necrosis leading to thrombosis of the vessels before detachment. Okay, in the completion there is annular detachment of the cervix. Then another problem, it can be rupture of the uterine, especially in the lower segment. There will be rupture of the uterus, but not in the upper segment, in the lower segment. There is chances even in the upper, but more common in the lower segment. Then postpartum hemorrhage, particularly if cervical lacerations extend. Okay, if cervical laceration extend upward, tearing the main uterine vessels. Here there will be even maybe the baby or deliver the baby, or because then what happened, there will be postpartum hemorrhage because of the trauma of the cervix. Then in management, organic dystocia, too, we have to send the mother for cesarean section is the management of choice. Okay, if it is because of the organic dystocia, mother will undergo cesarean section. Then functional dystocia, pethidine and antispasmodic may be effective. Cesarean section if medical treatment fails or fetal distress develop. This is the how we will manage the cervical dystocia. Okay. Okay. Now we already discussed. Now I come to the end of my topics. That is abnormal uterine contractions. I didn't prepare any other class, so you understand now what are the different means abnormal uterine contractions, right from precipitate labor, hypotonic uterine inertia, then constriction ring, then different types like spasmodic and colicky pain. All those things will come there in the different types of abnormal uterine contractions and its management we already discussed. So you please study, then I will give you test on this. Okay, we'll stop the class here for today. My class will stop here for today. Then the next I will not Monday again I will continue the class. Monday is Mam Dari will take class for you. Then Tuesday I'll take. Okay, so we'll stop here only.
Thank you, ma'am.
Thank you.